everybody. Welcome to McLean Hospital's Personality Disorder Education webinar series. My name is Catherine Brogy. I'm a clinical social worker here at McLean and lucky enough to work closely with our speaker this evening, Dr. Elsa Ronningstam. Before we begin, I just wanted to make people aware of a couple of logistical announcements, including to maintain your confidentiality, all of the microphones have been muted, and no other participants can see your name or email address anywhere. We really do want this to be an interactive process this evening, so we ask that you type any of the questions that you might have into the question and answer box in the bottom right corner of your screen. We encourage that you type your questions in at any time so that we can put them in a queue, and we'll do our very best to address them at the end of the presentation. In the lower left hand of the screen, there are several resource links that you can click on to get more information about borderline personality disorder, as well as to register for our next webinar, which we'll post information about at the end of this presentation. All of our webinars are recorded and posted shortly after the presentation on our website, McLean Hospital's website. And lastly, I wanted to acknowledge that this initiative is funded by a generous donation from a family who has been affected by borderline personality disorder. I'd like to introduce our speaker this evening, Dr. Elsa Ronningstam, who is an international expert on the diagnosis, treatment, and research associated with narcissistic personality disorder, and will be talking with us tonight about narcissistic personality disorder, in particular in young adults. So it's my pleasure to turn the microphone over to Dr. Ronningstam.
Thank you, Catherine. We are going to talk about narcissistic personality disorder, but also about narcissism and pathological narcissism and the differences in how all this is perceived and identified today. We are also going to take a look at some specific difficulties that people with narcissism, pathological narcissism and NPD, narcissistic personality disorder, are struggling with. And we are also going to take a look at some comorbidity with substance use and borderline personality disorder. Let's see, now this doesn't, so first of all, what does narcissism mean? In today's society, narcissism has a broad range of meanings and is used in very different contexts. And I want to start there to create a foundation for our discussion here. Because narcissism has unfortunately become a very pejorative label. At the same time, it's also associated with healthy self-esteem. It has been considered opposite to altruism because it's more self-focused. On the other hand, altruism has its base in narcissism, wanting to come across as a good person. It's a clinical diagnosis, psychiatric diagnosis, well established by now, and it's also a cultural trend. It's used in sociological, social, political context. As a disorder, it's considered what we call spectrum disorder. It's something that can be associated with high functioning or low functioning. It can be associated with more of the extreme or provocative external expressions, or it can also be associated with very difficult internal, hidden challenges. It's something that is associated with the self-deficit or vulnerability, and it's also associated with aggressive destructiveness, and the opposite, exaggerated sense of self-importance. With this, we shall focus now on, that. The normal, healthy narcissism, which is something that is common for everybody. It's a sort of a normal aspect of personality functioning. It has to do with self-esteem, self-confidence, self-preservation, self-protection, self-regard, sense of self-agency, in the sense that we feel that we are in charge of what we are doing and deciding, and with our mind, and a certain direction. You're taking a step in this direction. You have a sense of control over what you are doing. That is something that maybe has not been so common in association with narcissists. It's a normal sense of entitlement. We have the right to vote. We have the right to health care and deserving securities and standards and the predictability. It's about affect regulation, so self-conscious emotions such as guilt, shame. It's about empathic ability, which consists of both the cognitive and the emotional. It has to do with wisdom, humor, and creativity. There's also something called heightened narcissism. And heightened narcissism has to do with charisma, leadership, something that makes a person outstanding in some or another way. Status, fame, wealth. It's included in competitiveness, performance, and it's also associated to confidence and assertiveness. Then we have lowered narcissism and lower self-esteem. Masochism, martyrship, this thing of suffering, and one's self-esteem being associated to feeling lower than other people. It's often associated with passive aggressiveness, insecurity, self-denial, avoidance, sense of being a failure or expecting to fail, feeling undeserving, and often associated with emptiness, boredom, being outside, and such things. Narcissistic personality disorder was introduced in the DSM-3 in 1980, and it has remained relatively unchanged since then. This is what we call a trait model. And to meet this diagnosis, we shall meet 5 out of these 9 criteria. And the trait model identifies narcissistic personality disorder as present or absent. So there is a sort of a very regulated way of looking at this. Grandiosity and grandiose fantasies, being special and unique, for instance, require admiration and attention. And then we have the 4 E's: entitlement, exploitative, lack of empathy, and envious. And recently, arrogant, haughty personality features was also added. However, there have been a number of criticisms towards this diagnosis, because it isn't that simple with personality functioning, that you either are or you are not. And some of these traits that has characterized, identified NPD, also sort of on the normal side of or not necessarily pathological. So in DSM-5, in 2013, there was a new proposal, namely to look at personality functioning in terms of dimension. So we have a range and a fluctuation and more of a process in the personality functioning. So they identify in this proposal, personality disorder is identified as an impairment, and there can be different grades of impairment. So the impairment in self-functioning, identity and self-direction, and impairment in interpersonal functioning, empathy and intimacy. And in addition, there are two pathological personality traits. So this alternative model, which is a work in progress, is under the research and debate right now. For narcissistic personality disorder, identity is described as excessive reference to others for self-definition and self-esteem regulation. My professor likes me, for instance, I'm good. Or my coach thinks I am the best baseball player. Or something, or I am in the top group in my high school, or something in that range. There is also a self-esteem that can be both, or self-appraisal, self-evaluation that can be very inflated or very deflated, or they can also fluctuate in between. It isn't now so that narcissistic personality disorder is just about grandiosity. It's also about vulnerability, inferiority, insecurity, and the fluctuations in between. We should talk more about that. Emotion regulation mirrors fluctuation in self-esteem. So emotions and self-esteem are closely intersected. So that high self-esteem can be associated with specific feelings. Low self-esteem are usually associated with shame, sadness, some anger, and such things. Self-direction is also a very important dimension. Self-direction is somewhat of a overarching word for self-agency, namely the sense of that you are in charge of who you are, what decisions you make. And one thing is that gaining approval from other people is very important for goals and the intention. Personal standards can be unreasonably high, or they can also be low and based on that other people should provide. And in this model, narcissistic patients are often unaware of own motivations. Empathy is considered a impaired ability. There is no longer the idea that people with MPD lack empathy, and we are going to talk more about that. It's an impaired ability to recognize and identify the feelings and needs of other people. It's also a tendency to be very attuned to reactions of others, but only if they are perceived as relevant to oneself. Another thing is the unawareness of what effect one has on other people, that it can be a very provocative and difficult thing of knowing that you provoke, you irritate, you aggravate others, for instance, or you hurt or humiliate others. Intimacy is characterized with superficiality, little genuine interest. It's often based on self-esteem. I have the most attractive girlfriend in college, for instance. It's not so much who she is, it is that she is the most attractive. And there is also a need for gain in relationships to other people. And the two pathological personality traits in this model is grandiosity, the feeling of entitlement, self-centeredness, sense that one is better than others, it's attention-seeking, efforts to attract and get admiration from other people. There are a number of things, features and functional fluctuations that are typical for NPD in addition to the diagnostic criteria, things that have come up more in clinical studies. Compromised ability to recognize, tolerate, and process emotions. They're going to talk more about that, especially rage, shame, and fear. Hypervigilance, hypersensitivity, a need for control, and fear of losing control. Perfectionism, aggressivity, avoiding or dismissing other people. Underlying narcissistic trauma is something that just recently has become more of a issue in narcissistic disorders, and potential suicidality. NPD is has should we say, a different range of prevalence. General population is around 6%, a little more common in men than in women. In clinical population, it's more frequent, and in private practice, it's most frequent. They are also going to attend a little to the prevalence of substance use, since that is a major issue in among young people. And substance use are quite common in as a comorbid disorder or condition in narcissistic personality disorders, over 60%. Alcohol dependence is 30%. But NPD can also co-occur, but substance use is primary, but that is much less common. Etiology, what do we know? There is an inheritance factor with hypervigilance and aggression. There are attachment patterns in early attachment between parent, caregiver, and the child. It can be dismissive, avoidant, anxious, preoccupied, can't classify. Psychological trauma can be a very important factor, and psychological trauma are different from regular trauma, where you have sort of a identifiable event, often combined with abuse or other real difficult experiences. Psychological trauma can remain very unseen and to other people, but can have a major internal weight inside and be very challenging to handle. And I should talk more about that too. And then we have age-inappropriate role assignments, which is sort of the parentified child, or the child that from very early on has been assigned to be the fourth generation of medical doctor, or the first lawyer in the family, or something like that. So, what is that? Oh, I see. Okay. I wasn't prepared for the thing here. So, what affects self-esteem? Because self-esteem is something that is very personal, and we attach self-esteem to very different things. And this is very important for especially in younger people. Some people are very task-focused, performance-based. the best tennis player in my school, or I score ace, or something like very concrete. For others, it's more interpersonal. I have very good friends, for instance, or I have the most attractive boyfriend in my community. For others, it's socioeconomic or affiliation based. I am going to the best college, for instance, or I am the youngest with the highest income in my corporation, and something like that. But it can also be very internal. I know that I am good at what I'm doing. Even if there are rainy days or there are sunny days, there is sort of a self-focused internal confidence. Self-esteem can fluctuate, and that is one of the more challenging things with narcissistic pathology. And it's also one of the core disturbances. It's a hypersensitivity to criticism, for instance, or to threats to the self that can immediately lower self-esteem. But on the other hand, a straight A or a praise from somebody can increase self-esteem. And there is this fluctuation in between these. Some may be on the forefront, others on the back burner, but the core of narcissistic pathology is about the coexistence of both these aspects of self-esteem. It can also be what we call context dependent. Some people are, a person, for instance, felt very good as a swimmer, but had more problems with the academic course, especially writing papers, but no problems in sports. Self-esteem fluctuation, as I mentioned before, can co-occur with emotion fluctuations. So sudden shame, lower self-esteem. Sudden anger can paradoxically increase self-esteem. And self-esteem also occur together with intense reactions. And reactions can serve to protect or increase self-esteem, but it can also be trigger inferiority and deficiency. Perfectionism, that's a tricky thing in today's society, because perfectionism is reality and necessity in many situations. Nobody wants to attend or go to an eye surgeon who isn't going to do a perfect job, or get on the plane where the pilot isn't going to do at least close to a perfect landing. But for narcissistic people, the perfectionist becomes somewhat unrealistic and so associated with self-esteem and self-value. So to be to do something perfect means that I am perfect and I have to be perfect and feel perfect. And perfectionism can be to conceal something that is not perfect, but it can also be a way of promoting oneself. And it can also have a protective form by having a perfect self-presentation or intention to be perfect. That means that you protect yourself from imperfections. And doing and being perfect becomes the same thing here. We should take a look at vulnerability and self-devaluation. That is something that we maybe not so automatically associate with narcissism or narcissistic personality disorder, because we are used to think about the narcissist as the opposite, this self-enhancement and sort of coming across as the best and so on. But underlying the self-enhancement is the vulnerability, and it can easily be bypassed and being unnoticeable because especially when there is a capability of being confident or high functioning or knowing certain things. Some people with MPD can be more openly vulnerable or insecure and shame-ridden, and this is sort of the range of presentations in MPD. This vulnerability can be associated with the need to hide, for instance, that attention from others is very uncomfortable, or hypersensitivity to criticism, or having intense reactions, especially related to shame or aggression, or intolerance of feelings, which we are going to talk more about. Or this can be also something that can be noticeable in a very specific situation when there is an ultimatum or a failure, or there is sort of a loss of control and there is no way out. NPD and pathological narcissism has more recently been clearly associated with what we call alexithymia. And alexithymia has to do with difficulties understanding, identifying and feeling the feelings. And that can be either because of an unawareness or because of an inability to distinguish the physical and emotional state. So for instance, a person can feel something in the stomach, but I don't know whether it's shame or it's anger or it's sadness or irritability, and the reaction that this stomach, the psychophysiological sensation creates, can be very difficult to understand, both for the person, him or herself, and for people around. And it can be quite provocative. And this is part of the provocative facade that people with MPD can struggle with. And again, this deficit also creates difficulties to fully understand other people's feelings. And then often in today's society, and especially in the social context, this deficit can be combined with sort of a verbal fluency, plasticity, easily, and a great ability to say, oh yeah, I feel this, and I felt that, and now I feel this, and so. But the verbal description is separate from the internal emotional base for a feeling. And that can create a confusion for other people, because somebody can come across as more emotionally engaged than they actually are capable of being. And this is something where neurological research have added much more solid evidence in more recent years. But it's also evidence that shows much more complexity when it comes to empathic functioning, that complexity that is far beyond just having or not having empathy. So in other words, it's compromise but not a lack of empathy in narcissistic personality disorder. And that can result in a number of different reactions. Total ignorance, avoidance or dismissive responses. I see you're crying, but I don't care. Or aggressive responses. Why are you crying? Or extraordinary extraordinary attentiveness to care, but only if that is something that is associated to coming across as a good person. And this can be challenging for other people, but it is based in an inability to integrate feelings with perception and understanding of others. And it's also can also be integrated with the motivation that to come across as a good person. That means too that there is recent research identified the difference between emotional empathy and cognitive empathy. So people with narcissistic disorders, pathology, can usually see cognitively and understand if somebody has feelings. You can understand, for instance, somebody got hurt because I said, because of this and this happened, or even because I said this and this. Or you can see that somebody is crying. But the reactions to it can be very, very different because of an impaired emotion recognition and tolerance of other people. I see somebody say, I see that you're crying, but I can't tolerate all this, so I have to leave the room. And this can be a shame-driven withdrawal, or it can cause self-criticism, or it can cause a loss of control to face both one's own and others' feelings. So in other words, and what we are unfolding here is much more of complexity to empathic functioning in narcissistic patients. On the other hand, also some can be very tuned in and engaging and inviting to a certain degree, but not being fully able to relate and respond. Then that's what we call deficit-based empathic function. We are also the motivational based, that somebody have more capacity, but it doesn't want to engage. I'm up for a promotion. I can't deal with people's feelings because they are angry that something got wrong or was unfair. Or that there is an engagement when there is a concordance, a match between positive self-esteem and attending to somebody else. So this is a complexity. And we can see that there is a range of empathic functioning in narcissistic people. They can appropriately empathize under certain circumstances when they feel in control and when their self-esteem is not challenged. So they can empathize with some others' positive feelings, but not with their negative feelings, and vice versa. Especially the positive feelings which can be success related. But on the other hand, there is another situation to those who are more influenced by envy, can be unable to tolerate others' positive feelings or others' experience of positive events. And that's different from those who are more mirroring themselves with others. And they can really empathize with others' success and self-enhancement or success, and because it is an opportunity for their own self-enhancement. And then we have those who readily feel contempt. They can find others' defeats and losses so intolerable, and it can more trigger their own superiority or perfectionism. And some people, when they feel confided in, can access more of empathic ability because they feel in control, they feel valued, and so on. So, we should say a little about the narcissistic emotional trauma. As I mentioned before, this is a relatively new thing that has been incorporated in our understanding of narcissistic personality functioning, because it's caused by primarily an internal self-experience or a subjective perception and an experience of an external event that threatens the continuity, coherence, stability, and well-being of the self. And it may or may not be at all understandable or noticeable to other people. Example of this is, for instance, 5 college kids were assigned, college students were assigned a C on a paper. And one said, okay, I didn't like this subject, so I go out and have some fun with my friends. And another said, okay, my parents are going to be very angry. A third said, well, I should have studied more. And the fourth said, well, this is not my subject. I should go and do something else. And the fifth said, this is a failure. I am a failure. This is something that it just sets a tone for the rest of my life. So this is, and for that fifth person, this became a real traumatic experience, an ambition of being rejected by parents, being kicked out from college, etc., etc. It's not a psychotic experience, but it is what we call a subjective experience. And these types of experience can remain non-verbalized, compartmentalized, and hidden for a long time in life, but still play a major role in lowering self-esteem. So sense of failing, loss of self-esteem, and efforts to organize and understand and find meaning or explanation to these types of traumas can lead to underlying very stable long-term narcissistic patterns and tendencies that may require quite a treatment. We should take a look at narcissistic challenges in late teens and young adulthood. Because this is a time period in life that has been considered very difficult from a narcissistic point of view, including a bunch of challenges. It's competence, attraction, competition is part of life, dependency versus independence, moving on from being dependent of parents, family to more independent but still being dependent, and what type of dependence and how to move forward and still being dependent or more independent, that can be a very challenging balance. Sense of identity, knowing who I am, not knowing, searching, avoiding, being preoccupied with who I should be or not should be, all these kinds of things become a real important thing. Shall I become the next medical doctor? Shall I become a hairdresser? Although my grandfather thinks I should become a lawyer. And there are these really tough things. Do I want to become a parent when I'm in my early 20s, or shall I wait until I'm 30? What would be the difference? Affiliations, belongingness, what college, or shall I go to college, shall I not go to college, and which, friendships, dating, facing differences, loneliness, being an outsider, all these things are real challenges for them in late teens, early 20s. In this time period, there is also a higher risk for addiction. Because of the heightened narcissism, it's substance use can add to a sense of control of uncontrollable emotions and identity difficulties. It can become an idealization of substance. It can become a way to deal with social environment, but it can also be associated to a failure in normal pro-social environment and increased risk for substance use disorder. And NPD can be a predisposing factor to addiction or a secondary consequence, but it can also be a what we call it reciprocal or mutually increasing each other. I need a drink before I take my test, for instance, and then I need a drink after the test, and so it's differentiating this is actually very important. So, sum up a person struggling with pathological narcissism and MPD: confident, arrogant, insensitive or charming facade, but shifting and conflicting sense of self, and sometimes they have to stress and make aware of that the internal struggle for these people, especially in their young age, can be quite difficult and significant. Perfectionism, excessively self-critical and judgmental, and there is a strong reaction to threats to self-esteem, humiliation, defeats, perceived envy from others, others' criticism or inattention. If you take a look at some overlap, borderline traits in NPD, borderlines are easily overwhelmed by their feelings, but they have a better capacity for tolerating ups and downs and better capacity for emotional empathy than narcissistic patients. However, when narcissistic traits co-occur in borderlines, they can actually have more of a stabilizing effect. Perfectionism, high aspirations, need for control can really contribute to that. And then we have a very specific color of self-destructive preoccupation in narcissistic borderline patients. So narcissistic patients have a higher capacity for impulse control. That can lower self-destructiveness in the borderline patients in narcissistic features. But the thing is too that sometimes a controlled self-destructiveness can be an effective way to regulate feelings and maintain a superior control. So it's a little complicated with what can have a constructive effect and what can have a more controlling effect, but it's still with borderline pathology. People with NPD often do not seek treatment and seek treatment first when something has been going quite wrong, or they have come to an eye-opener that something is really needed. There can be ultimatums from family, employers, court, school. For instance, if you don't seek treatment, you will be XYZ. It can also be a realization that life isn't going the way I want. Can't reach these goals, can't get these dates I want, can't get into the school I had aspired to go to. It can be acute crises, financial, personal, something really serious happens. It can also be onset of mental disorder and suicidality, which can be quite sudden and serious in patients with NPD. And the last thing I'm going to talk about is how to explain the NPD diagnosis. diagnosis, because that is a tricky thing. Somebody who is assigned or suggested that they have narcissistic personality disorder often have a very negative reaction, and it is not so simple as, for instance, having obsessive compulsive disorder or a substance use disorder, where you have very concrete evidence of an acceptable problem. But NPD is about self-esteem and fluctuations between feeling okay or good, in charge and in control, and confident or appreciated, and then feeling insecure, ashamed, afraid, humiliated, or rejected. So there is that discrepancy, this dialectic that needs to be put on the forefront. The second thing is how each person handles these challenges associated to this dialectic. So how to make an effort to sustain or enhance self-esteem, to handle inferiority or self-doubts or interpersonal problems. And people who have more externalized interpersonal problems and encounter collisions, misunderstanding and criticism, they can come across as more self-sufficient, entitled, or angry or aggressive or dismissive. But that's because the narcissistic problems are more external. Then we have also people who are struggling much more with internal struggles, high aspirations, insecurity, a lot of self-criticism, self-hatred, shame, fear, and such things. And there they often struggle with serious loneliness. And for most people with narcissistic pathology, both these sides are present, although one can take the forefront and the other can take the back, go on the back foot. Okay. As I say, just a few things about treatment. When it comes to treatment, especially of young people, it's very important in today's society to have a solid initial psychoeducation about what pathological narcissism and narcissistic personality disorder actually is about. Basically because it's so intimidating and so often shocking to have that experience. So initial psychoeducation serves to strengthen the narcissistic patient's sense of internal control and agency. This is what I have and this is what it is. And I can identify with this and this and this and these types of problems. So that the education and the patient's experience of their own problem makes sense in formulating and understanding the diagnosis. And that also motivates the patient to begin to look at what they need to work on from their own best self-interest. It's also a decrease of fear of the unknown and for a fear of loss of control. And that means that the approach to treatment as a collaborative thing, a collaborative process is a very important thing. People who seek treatment with narcissistic problems can often come to say that, okay, well, I'm here because my teacher or my parents have told me I have to go to treatment, so what can you do for me? And often that is more a sign of avoidance of taking charge of own problems, and it can fail to be helpful. So this is the important thing to engage and make the patient more aware. And also it can support the patient's own motivation and courage to engage in treatment. And treatment and change can be very frightening and challenging, especially for people struggling with self-esteem. And to get a motivation and understanding of the purpose of looking at deeper emotions, deeper conflicts, deeper way of subjective internal ways of functioning. So that is psychoeducation serves a very important function. DBT can be very useful for some people and very challenging for others with NPD. For instance, people who want to have concrete skills to deal with certain situations. I know I get angry, for instance, in this situation. I need to learn emotion regulation skills. There, DBT can be absolutely super productive. But for other people, DBT can feel too simplified. They feel that their problems are more complicated and that it may not work as well. Schema-focused therapy has been specifically outlined for and adjusted for MPD, and that's a cognitive approach, a cognitive behavioral approach, and it also includes some transference techniques to work on schema modes, which are typical for MPD. And it focuses on changing the patient's intimate relationships and also address narcissistic cognitive distortions, black and white thinking, I don't want to be with you because you are not measuring up to this, and those kinds of things. Another treatment that is in the process of being adjusted to NPD is transference-focused psychotherapy, which originally was focused on borderline personality disorder. And that attends to patients' narcissistic defensiveness and underlying aggression, and also the way they can relate in split ways. Others are good, I'm bad. Others are bad, I am good. And it activates more of interactive, interpersonal exploration. And it's also adaptive and flexible to different levels of narcissistic pathology. Psychopharmacological treatment is it can work when patients have comorbid axis-bound disorders, for instance, bipolar disorder, depression, anxiety, and so. But we also have to keep in mind that patients with NPD can be hypersensitive to side effects, and there is no specific psychopharm therapy for pathological narcissism and NPD. So.
Thank you, Dr. Ronningstam. A couple of questions that have come in that are related around how parents and families can help their loved ones want to get care, how to encourage them, and what can they do to help them seek it out.
Well, first of all, I think that trying to sit down and talk in a respectful, reality-anchored way of problems that are noticeable and can be agreed upon with the teenager, young adult, the family member. Because as soon as you can get an agreement, there is a better chance for motivation. And to be able to find a way of talking, an atmosphere, a way of communicating that can help them, the family member to talk more openly about their own subjective struggles. So because these types of discussions can easily become like explosions or volcanic outbursts, and it ends up in just worse, more accusations and more blame and more this and that and distancing. But to avoid that, finding some areas where there can be an agreement, and then to see if that agreement can be a motivation for seeking help.
Has there been research conducted on the co-occurrence of ADHD and NPD or other addictions such as pornography addiction and NPD?
Attention deficit disorder, yes, I think that has been sorted out, but they can co-occur to a certain degree, and the question that is in what way the ADHD affect emotion regulation and attention in a way that supports avoidance or that can lead to failure. So combine them, ADHD and NPD can have a complex co-occurrence that can both support narcissistic tendencies but also lead to increased insecurity.
What about the biological or genetic predisposition for such a disorder as narcissistic personality disorder?
But as I mentioned, that there is evidence so far of hypervigilance and aggression as part of inheritance. Also, the very early attachment patterns can play a major role, but it's sort of a gradual process in the development of NPD that life experiences and other things can add to it. So just because somebody is born with hypervigilance or more profound tendencies for aggressivity doesn't mean that they end up with NPD.
Do we see a higher occurrence of NPD in certain subsets of populations across society?
I'm not aware of studies of that right now. This more looked at sort of comorbidity and those kinds of things, but I don't think that there has been anything that has specified. So there are more age groups, more competitive environments, for instance, that can increase sort of narcissism in terms of more general social functioning. But for NPD, I don't.
Well, thank you very much.
Thank you.
Please, everyone, refer to your screen for the next webinar hosted by our visiting Professor Martin Bohaus from Germany, who will be presenting on April 12th on borderline personality disorder and the co-occurrence with post-traumatic stress disorder and associated treatments. You can